Thanks so much, everyone. Again, welcome to this NephCure U on adrenal suppression or adrenal insufficiency. My name is Kristen Hood, and I am NephCure's Director of Clinical Outreach, and I'll be the moderator for today's educational webinar. We have an amazing physician here today from the University of Colorado and Children's Hospital in Colorado to speak with us today. Before I introduce her, I would like to ask that all attendees, if you have questions for our physician, please, at any point during this webinar, please go ahead and drop them in that Q&A function down at the bottom of your toolbar, of your Zoom toolbar. Enter those at any time. We will have some time at the end of the webinar to answer some questions. We will get to as many as we can. We do need to respect Dr. Chambers' schedule today because she is in clinic and has patients to see as well. So this webinar is being recorded and will be posted to NephCure's website as a patient resource. And I'd like to recognize NephCure sponsors who help make programs like this possible. Travere Therapeutics, Goldfinch Bio, Mallinckrodt Pharmaceuticals, and Boehringer Ingelheim Pharmaceuticals. So thank you so much for supporting NephCure this year. And now it's my privilege to introduce Dr. Christina Chambers. She's an attending endocrinologist at Colorado Children's Hospital, and she's also an instructor of pediatrics and endocrinology at the University of Colorado Boulder. She is double board certified in pediatrics and endocrinology and sees a wide variety of patients with conditions relating to the endocrine system, of which she will be going over today. I know we're all excited to learn more about the endocrine system, especially today's hot topic. It is always a hot topic for us here at NephCure within our patient community around the adrenal glands, why they're so important to us, and what happens to them whenever we take steroids. So we always see a lot of questions relating to the signs and symptoms of adrenal insufficiency. So we have an expert here to talk to us all about that and to teach us more about it. So thank you, Dr. Chambers, for being here. And with that, I'm going to turn this over to you.
Wonderful. Thank you so much. Let me see if I can share my screen here appropriately. The fun with Zoom here. Are you seeing the slideshow?
Yes, ma'am.
Are you seeing the?
I'm seeing the right slides for us. Yes, it looks great.
Perfect. Okay, wonderful. Thank you so much. I really am quite pleased that you have all recognized the importance of the adrenal glands. All too often, we get patients in when we're getting them in crisis, and we know that this can be prevented by acknowledging that there is a risk for adrenal insufficiency when people are on chronic steroids. And so I'm very privileged to be here to talk to you guys about this, and I welcome your questions and anything that comes up as well. First, I have no commercial ties, no conflicts of interest. And I want to start off by really going into the adrenal glands themselves. So your adrenal glands live above your kidneys. You have two, a right and a left. They each layer of the adrenal glands have a job. So within your adrenal glands, you have a medulla, which is the internal part of the adrenal gland, and the cortex. And each layer of that cortex will have a unique set of enzymes that produce unique sets of hormones. Now, at birth, adrenal glands are pretty large. They're a third the size of a kidney. So, in comparison, the adrenal glands are quite large. But due to maturity of the kidney, as well as involution and maturity of the adrenal gland themselves, by adulthood, adrenal glands are only about a 30th the size of the kidney. So when we do ultrasounds in infants and young children, we're able to see the adrenal glands pretty well. But it takes usually CTs or MRIs to get a good view of adrenal glands in adults. Now, looking at the medulla is where the center of that adrenal gland. So this is basically an image of if we were to cut through an adrenal gland. The medulla is where your catecholamines are released. So catecholamines are those fight or flight hormones. Think of those as like your norepinephrine. These are your adrenaline hormones. These hormones are actually stimulated by your sympathetic nervous system. And then in the cortex of the adrenal gland, that's where we have our different layers, where mineralocorticoids are at the outermost layer, and that's where salt hormones that are involved with salt are basically kept. Glucocorticoids, which are in the middle layer, and then your androgens, which are your sex hormones like testosterone, are in the innermost layer. A little bit about the history of the adrenal glands. So they were first described in the mid 1500s. And then it wasn't until the 1800s that Brown-Séquard, by taking the adrenal glands out of cats, discovered that you really need those adrenal glands for life. In the later 1800s, it was found that if you give people with adrenal insufficiency oral pig adrenal glands, they're able to actually stay alive and do well. But it wasn't until the 1950s where the anti-inflammatory effects of these hormones were able to be seen with rheumatoid arthritis. And that really provoked a lot of more research into steroids. And in the 1950s, a lot of these natural steroids were modified, resulting in the production of prednisone, which we all know can be life-saving and a really important hormone for the management of a lot of chronic autoimmune diseases. So when we talk about steroids, and I do use steroids pretty liberally when I talk about them, but really steroids, the term for that is a combined, it's a word that basically combines a whole lot of different types of hormones, but they all have a characteristic chemical structure that has 4 carbon atom rings. But there's many hormones that are considered steroids, like testosterone, aldosterone, corticosterone, progesterone. You'll note that many of these have the ONE at the end of their name, like prednisone, dexamethasone, hydrocortisone. That gives you a clue that these are steroids. Now, glucocorticoids are a particular type of steroid that is made in the adrenal gland. Cortisol is what is largely produced. So when we talk about cortisol, that's equivalent to hydrocortisone, the medication. There are different levels of potency of steroids. So prednisone is about 4 times as potent as hydrocortisone. So when we have one milligram of prednisone, that's pretty much equivalent to about 4 milligrams of hydrocortisone. Methylpred is about 5 times as potent as hydrocortisone, and then dexamethasone is about 20 times as potent as hydrocortisone. I basically like to think of it as dexamethasone as your sledgehammer, methylpred and pred, these are your hammers, and then hydrocortisone is like your ice pick. When we talk about cortisol, how this is secreted, so again, coming from that adrenal gland, well, it starts actually up in your brain. You have a hypothalamus that secretes a hormone, CRH, to your pituitary, which then stimulates the pituitary to secrete ACTH that goes to the adrenal gland and stimulates cortisol. Cortisol's job is to increase your blood sugar, increase your blood pressure, and have those anti-inflammatory effects. This is critical in times of stress, and I'll go into stress in just a little bit. Cortisol then has negative effects up in the brain, on the hypothalamus and the pituitary to decrease their secretion. So if you're making a lot of cortisol, then your cortisol responds back to the hypothalamus and decreases the amount of CRH, and then the pituitary decreases the amount of ACTH made so that you're not just making cortisol and cortisol and cortisol and cortisol. It's got this nice axis that is under tight control. Normally, cortisol is secreted on a daily basis. So when we talk about stress and when we talk about crises, That's an important aspect of cortisol, but we also need cortisol on a day-to-day basis. When cortisol is secreted by the adrenal glands, it's secreted in a diurnal pattern. So you get a peak in the early morning hours, that tapers off in the afternoons, and we all feel that right around after lunch. And then at midnight, you're at your lowest level of cortisol secretion. So this is a diurnal. Morning you're peaking, at night you should be very low for your normal cortisol production. We talk about cortisol then for our normal maintenance cortisol secretion, and then what we need when we are under stress. Our normal maintenance cortisol is a baseline secretion of about 10 milligrams per meter squared per day. Stress, when we need much higher amounts of cortisol in our body, is about 50 milligrams per meter squared per day. Stress, I'm going to mention this a few times here. So stress includes things like surgery, anesthesia, trauma, broken bones, severe illnesses, fever. Think of things where you will drop your blood pressure or your blood sugar. You need those up. Okay. Psychological stress, psychological stress can also, over long terms, also increase your cortisol secretion. But in the acute need for keeping up your blood pressure and your blood sugar, it's generally those situations where you are under a lot of physical stress. So the next question I often get is, how do we find our meter squared? So there are a lot of formulas to figure out your meter squared. These are the formulas that we use most often, Dubois and Mosteller. However, in the day of the internet, you can just really go ahead and Google a BSA or meter squared. So BSA, stands for body surface area. A BSA or meter squared calculator, and you can easily figure out what your meter square is. And so then how do you find your meter square per day in the dose of the steroid that you're taking? So take your steroid for the day, say that you're on prednisone, convert that into the hydrocortisone equivalent, because remember, hydrocortisone is equal to cortisol. If you're on 1 milligram of pred, that's about 4 milligrams of hydrocortisone. You then divide that by your BSA. So for example, an adult with a BSA of 1.8 taking 20 milligrams of prednisone a day, you'll multiply that 20 milligrams of prednisone by 4, and that's going to give you how many milligrams of hydrocortisone equivalent you're taking. That's about 80 milligrams. You then divide that by the BSA of 1.8, and you've got 44.4 milligrams per meter square per day of hydrocortisone equivalent. So that then goes back to our normal cortisol secretion, right? If you are on 44 milligrams per meter square per day, you are taking more than your maintenance cortisol needs for the entire day. And you're pretty close to what stress dose needs. When you're taking more than your maintenance dose, that can lead into iatrogenic adrenal insufficiency. Okay? So iatrogenic adrenal insufficiency, just to be clear on what this means. This is when we have exogenous or prescribed steroid amounts that are more than the amounts that you would need to have for your daily dose, okay? So when prescribed amounts are taken at a high enough dose for a long enough time that it suppresses that hypothalamic pituitary adrenal axis, this results in the adrenal glands atrophying or shrinking and leads to insufficient, not enough, endogenous production of cortisol for stress needs. A serious consequence of iatrogenic adrenal insufficiency is adrenal crisis. Adrenal crisis is when we'll have low blood pressure that can lead to shock, and in severe cases can even lead to death. Additionally, iatrogenic adrenal insufficiency can occur if steroids are weaned or stopped more rapidly than the adrenal glands can recover. Then you can have insufficient endogenous cortisol production for just your maintenance needs. And in those cases, we'll see symptoms of adrenal insufficiency. And those symptoms are more chronic symptoms, more long-term symptoms of fatigue, nausea, weakness, lower blood sugars, which can result in fainting spells even, and diarrhea. So this is going back to that HPA axis. So if your cortisol amounts, if your hydrocortisone, your prednisone, your dexamethasone amounts are higher than what your body would normally be taking, those steroids are then suppressing the hypothalamus and the pituitary, and therefore the adrenal glands are getting no stimulation to make its own cortisol. Those adrenal glands, under lack of any stimulation, just the same way that a muscle without any stimulation to use will shrink and shrivel and become atrophied, that adrenal gland will also atrophy and will not be able to make its own cortisol when needed under stress. So what does this mean when you're on a steroid? So the tricky thing with iatrogenic adrenal insufficiency is there's no absolute cutoff. Most people would think if you are on doses of prednisone 20 milligrams a day or more, you're most likely at risk. But anybody who's on prednisone of 5 milligrams per day is still at risk, or 20 milligrams a day of hydrocortisone is at risk. Now in kids, we dose this more on the meter squared per day because kids are not just little adults. They are quite a bit smaller for their whole body mass. So in their cases, it might be lower doses of prednisone or hydrocortisone that could suppress their adrenal gland function. And then the duration of time, generally we consider about 3 weeks. If you're on a steroid, that's more than your maintenance cortisol production for 3 weeks or more, you're likely going to be having some impact on your adrenal gland's ability to make its own cortisol. Now, again, there's not an absolute cutoff here, and we can see this start as soon as 2 weeks, but generally 3 weeks. If it's more than 3 weeks, you can pretty much figure that you are at risk for having iatrogenic adrenal insufficiency, okay? So how do we diagnose this? Well, we diagnose this most often on blood work with cortisol levels. So we take a morning fasting cortisol that's obtained about 24 hours since the last dose of prednisone. So if you take your prednisone in the morning, you will take your, if you're taking your test on a Tuesday, you'll take your Monday morning prednisone, and you will not take your Tuesday morning prednisone, but you'll get your blood draw done at 8 a.m. ideally, fasting. And then you can take your prednisone right after that blood draw is done. And what we're looking for is we're looking to see what your body's own production of cortisol is when it should be peaking at the morning normally, okay? A cortisol greater than 11 is great. That is super reassuring. You really don't need to look much more into that unless you're having really severe symptoms. But in those cases, it's most likely not due to a lack of your body's adrenal gland's ability to make cortisol that's causing some of those symptoms, okay? A cortisol less than 5 is highly concerning for adrenal insufficiency. Now, then we have our gray area between 5 and 11. We don't have a great cutoff there for knowing who are going to be those who are having adrenal insufficiency and who are those without. If you have symptoms of adrenal insufficiency, so again, fatigue, weight loss, nausea, dizziness, lower blood sugars, that is concerning for adrenal insufficiency, even if your cortisol is 6 or 7. And in those cases, an ACTH stimulation test can be done. And what we do with that is we give cosentropin, which is basically a medication form of ACTH. We give that IV or intramuscularly, and then we check what the adrenal's response to that. Now remember, ACTH is that hormone from the pituitary that stimulates the adrenal glands to make cortisol. So if we give ACTH and those adrenal glands make a robust amount of cortisol, well, that's reassuring against adrenal insufficiency. If we're left with a response of 9, 10, 11, that indicates that the body is not able to respond to normal physiologic stresses and make enough of its own cortisol to match that. And that is diagnostic of adrenal insufficiency. So how do we treat adrenal insufficiency? Yeah, more steroids. So who needs this treatment? So if you're on enough daily steroid to suppress your adrenal glands, well, additional maintenance daily doses are generally not required because you're on a good daily dose. In fact, such a good dose that your body doesn't feel any need to make any cortisol of its own on a daily basis. However, under stress situations, again, fever, vomiting, significant trauma, surgery, broken bones, in those cases, you need more steroids in order to treat and prevent adrenal crisis from occurring. We give those stress doses, again, fever, vomiting, significant illness, trauma, sedation, shock, unconsciousness. We give an oral stress dose if possible. And usually that oral stress dose, we try to use the steroid that you're already on, but in some cases we do change that. And if unable, then that's where an injection of steroid can actually save a life. So Solu-Cortef Activile is a great, a very useful form of Solu-Cortef or IV hydrocortisone that can be given via an injection into the arm or the leg that we send kids to school and kids at home with in order to have a way to get their stress dose in when they're not able to take oral medications. There's a lot of flexibility in the treatment plans. For example, some plans say to double your dose if you're mildly sick, triple your dose if you're very sick. Others, like our program, we like to use a set dose. So if you are sick, you take this much hydrocortisone or this much prednisone every 6 to 12 hours, depending on the steroid that we use. We prefer to use a set dose because gosh, when you're sick, we really don't want to be having to do math. So we like to give people set doses of this is what you take when you are sick. And it's best that you come up with a plan with your doc that works best for you because some steroids work better for the different types of syndromes you might be treating, for the different types of symptoms you might be having as well. That stress dose needs to be individualized for your age, for your body surface area, for what current steroid you're on, for what current steroid dose you have, as well as if there's a history of glucose issues like diabetes. And I just want to bring this up that if you do have a history of glucose issues, dexamethasone is probably not the best stress dose steroid to be using because that can increase your blood sugar significantly, and unfortunately it can increase it for a long duration of time. So ideally we stick to hydrocortisone in cases like that, which have less of an effect on blood sugars when you use a stress dose. Additionally, in children who are growing, we prefer hydrocortisone as our stress dose because it has less effects on growth that prednisone and dexamethasone may have. An important point, never simply stop your steroids without first discussing it with your doctor. A big concern if you are taking steroids and you're worried that you have iatrogenic adrenal insufficiency, the treatment is not to stop your steroids because that will just tank you out and you will end up with no cortisol production for a duration of time. Now, a big question that I know is going to come up is recovery. Can you recover your adrenals? So you know that you are on, we're going to use our patient here, 44 milligrams per meter squared per day. That is covering maintenance needs, and we have stress dose steroid plan in place if there's need for stress dose. Well, what if we want to get off of those steroids over time? We are in good control of our disease. We feel like we're in a good spot where we can start to wean those steroids. It takes a long time. So general rule of thumb is it takes almost as long as you've been on those steroids to come off of those when you're on short term. However, when you're on long term, about 6 to 12 months after stopping the daily steroid is how long it's going to take for those adrenal glands to wake back up. The dose of the steroid, the type of the steroid, and how long you've been on wean all affect recovery. The goal of a wean is to minimize symptoms of adrenal insufficiency, in addition, of course, to minimizing recurrence of the disease, but at the same time allowing for adrenal recovery. An important note, if you have iatrogenic adrenal insufficiency and you're weaning your steroid, you still need stress dose precautions. You still need that stress dose plan. Continue until you've proven recovery of the adrenal axis, because stress is the final phase of adrenal recovery. And what I mean by that is when we're looking at adrenal recovery, the first phase is when we don't have as much excess or exogenous, so outside cortisol or steroid, then the hypothalamus is no longer getting negative feedback. So that hypothalamus starts to wake up and starts to make that hormone CRH. That's that first phase. It then stimulates the pituitary to start to make its own ACTH. Now remember, they're not under negative feedback. So they actually will start to go up and high. You can have high levels of ACTH in the second phase. But that high level of ACTH then really starts waking up those adrenal glands to start making more and more and more cortisol. And as that cortisol level gets back into the normal range, the ACTH, the CRH, those come back down into normal ranges as well. And eventually, we'll be able to get a full stress response that happens too. Recovery is possible. It really is. Those adrenal glands, they are important and they are biologically determined to really come back. It can take a long time and that can be very frustrating, but they can come back. It takes time, it takes patience, and honestly, it takes a degree of tolerance. So while tapering, if you remain on doses above maintenance, the symptoms that you're feeling if you are tapering, those are likely due to glucocorticoid withdrawal. And now, glucocorticoid withdrawal and adrenal insufficiency, a lot of that overlaps. A lot of those symptoms overlap. They can include things like the nausea, lower blood sugars, weakness, fatigue. You can also get some muscle aches and joint pains that can happen with that. You can also experience some psychiatric issues, some moodiness can happen with that. Now, glucocorticoid withdrawal is not comfortable, but it's not necessarily dangerous. What becomes dangerous is if you are experiencing significant levels of adrenal insufficiency. And again, those can be hard to figure out, but you can know if you're above maintenance doses still with your steroid, most likely those are glucocorticoid withdrawal symptoms. You still need those stress dose precautions as you wean, okay? When tapering though, once you're on doses that are below maintenance, the symptoms could be from withdrawal or it could be from adrenal insufficiency. There's a lot of these symptoms overlap. And it's not a bad idea at that time to consider transitioning to either hydrocortisone or adding in a little bit of hydrocortisone. For example, a lot of times on weans, you'll go to an every other day prednisone dose. And we hear a lot of times that on the day off of prednisone, people feel really weak. In those days, adding a little bit of hydrocortisone can really make a big difference in quality of life. Remember, hydrocortisone doses are significantly different from prednisone. So 1 milligram of that prednisone is equal to 4 milligrams of hydrocortisone. So if you're on those 5 milligrams of prednisone and you go down to 10 milligrams of hydrocortisone, you are on less steroid, okay? Okay, that's what I have so far. I was going to open it up to questions at this time. That works.
Yes, that works. We can definitely do that. All right. So we have a couple of questions in the Q&A section. If you have a question for Dr. Chambers, please feel free to enter it now. I am going to just kind of start from the top, from the first question that we have, Dr. Chambers. This is from one of our attendees. Says, I've been on prednisone for 8 years for IgM nephropathy. I started on very high doses and only recently have been able to taper down to 6 milligrams per day, thanks to getting rituximab infusions. Will my own adrenal glands turn on soon as I continue to slowly taper, or would that occur after I'm completely off the prednisone altogether?
That's a great question. And yes, your adrenal glands will turn on, but again, it's a bit of a continuum. So the adrenal glands start to turn on, but it's not likely going to be enough to cover for you to just stop necessarily. So it takes some time for those adrenal glands to recover, but getting down to 6 milligrams a day of prednisone is fantastic. And over time, those adrenal glands will recover and you have a better chance of it the longer that you're able to be on those lower doses.
Thank you. Another one from Mr. Lawlin. I've been on prednisone for nearly a year, varying dosages, and am now on a second taper after infusions of Medrol in December and 4 months at 10 milligrams per day. The current dosage now, he's down to 5, and he's hoping to be off by October. How can I know my adrenals are functioning normally? I know there are tests. The nephrologist has never mentioned testing adrenal function. What should I be asking him for? This is a great question.
That's a really great question. So when you're on prednisone of 5 milligrams per day, most adults actually do okay for adrenal function, but you've been on higher doses for a longer period of time after that, before that. So you definitely are at risk for adrenal insufficiency. The test that I would recommend is a morning fasting cortisol to start off with. And you would want to hold the morning's prednisone dose before taking that. The other thing, Kelly, that I forgot to mention is that the timing of when you take your steroid is actually really important. Remember how I said that in the morning is when you get your peak cortisol? Well, if you are taking steroid at night, that's having higher cortisol levels at night. That actually can have more suppression over time. So prednisone is a long-acting steroid. And when you're taking it at night, you're often able to fully suppress that morning peak, and that can have longer term effects. So that's another thing to consider is when you're taking it. If you're taking it at night, you have a higher risk for iatrogenic adrenal insufficiency. And again, testing that, you'll want to be off of a steroid for at least 24 hours to then check a morning cortisol level. And based on those cortisol levels of if it's over 11, you can be reassured. If it's under 5, you should be very concerned. And if it's in that gray area, if you are having symptoms of adrenal insufficiency, nausea, weight loss, low blood sugars, fainting, you should be checking in with an endocrinologist.
That's great. Another question, I'm going to tag along on that one because you're talking about when you take your dose of steroid. Yeah. So it is a common question of should I take it in the morning or in the evening? And then some people will say, well, I split mine and I take some in the morning and some in the evening. Is that also, would you just recommend the entire thing be taken in the morning so that they don't have any at night, or, does that make sense?
Yeah. So when you're on doses that are greater than 5 milligrams of prednisone a day, it honestly doesn't much matter. You are more likely to
Splitting
be,
them.
it more is a matter of when does it work best to take your medicine.
Okay.
When you're on doses of 5 milligrams or less, then taking it in the morning may actually help with adrenal function over time.
Okay.
And there's no great studies to be like, well, this group did this and they had faster recovery than the other. But the way that we know cortisol secretion to work, if you are on lower doses and want your adrenal glands to be kind of kicking in a little bit more, that morning dose might be a better timing for it.
That's
Splitting
good
the
to know.
dose of prednisone is not as helpful if you have symptoms from taking the prednisone, but it is a long-acting medication. It is in there for 24 hours pretty much. So it doesn't necessarily change adrenal function. We consider
Okay.
that a total daily dose.
Okay. Okay. Diane is asking if you wouldn't mind sharing your screen to show the formula again. So Diane, thanks for that. We'll get that done easily. Another question is, when should I seek care from an endocrinologist? And I'm going to kind of follow up on that as far as, I am also a patient parent, and my child was diagnosed with minimal change disease 4 years ago. And he's been on steroids for probably 3 out of the 4 years, off and on. And we've never had, the nephrologist has never given us had this conversation with us. So I'm kind of curious about, are there warning signs when someone should see an endocrinologist? Should they not wait until there are warning signs? And then as far as being an endocrinologist, are they all trained in adrenal insufficiency? And do they have, I'm kind of curious about the patient population that we work with, because in the rare kidney space, you probably know from taking care of patients in our space as well, that there are no FDA approved medications currently. So steroids is the #1 first line treatment for almost every single diagnosis that we kind of cover in our umbrella. And so I'm kind of curious, would an endocrinologist, are they as knowledgeable about this patient population as maybe you are?
So with endocrinology, steroids are our jam. We deal a lot with the after effects of steroids, and with the management of weans and picking steroids as well for weans. We know that for children in particular, children who are having growth cessation, so if their growth is stopping, they're looking particularly Cushingoid, they need to see an endocrinologist, because that is consistent with being on high enough doses of steroids that they may be adrenally insufficient. The reason that I gave the prednisone dose of 5 milligrams per day is that many people go off of total daily doses and they don't use a meter squared. All endocrinologists are taught to use milligrams per meter squared per day. All endocrinologists are familiar with that. But not a lot of nephrologists, rheumatologists, pulmonologists, I mean, the list goes on, hematologists, not a lot are very well versed in dosing steroids based on milligrams per meter squared per day, and use these set numbers, 5 milligrams, 10 milligrams, 15 milligrams. When we're dealing with adrenal insufficiency, 5 milligrams of prednisone, if you are on 5 milligrams or less of prednisone a day, the likelihood of adrenal insufficiency is not high. When you are more than that, though, every milligram of prednisone you go up on that, there's an increased risk of adrenal insufficiency. You're certainly more likely to have adrenal insufficiency if you're seeing symptoms with it. And that's why I keep stressing those symptoms. If you're having symptoms, you need to have this looked into, because what we want to definitely prevent is an adrenal crisis. Now, adrenal crises, there is, I don't want to scare you with that. There's usually a precipitating event. There's usually a fever or a flu or some illness. Urosepsis can bring that on. But the treatment is with steroids. So steroids can't be ignored in the treatment with adrenal insufficiency when you're also treating another type of infection. And so that's where it's important to have this diagnosed, because you need to make sure that the steroids are on board when you have a significant illness that could lead to an adrenal crisis.
That's great. I'm gonna go on to because you're talking about some symptoms. I'm gonna go on to Emily's question here, and then we can go back up. But Emily says her daughter has been on steroids for over a year and has been having recurring stomach pain, and she had an endoscopy. It revealed nothing, but she's had it ever since being on steroids continuously for 2 years due to her nephrotic syndrome. They've tried lots of things to help her, and she's wondering if the stomach pain is linked to the body aches that showed up with chronic steroid use. So my question, to kind of tag along with hers, is this a symptom of adrenal insufficiency, or can you review what those symptoms look like?
Yes, so adrenal insufficiency symptoms do include recurrent stomach aches, so recurrent abdominal pain, nausea, episodes of unexplained vomiting, weight loss, as well as fainting, dizziness, and diarrhea.
Okay, so her daughter's symptoms could definitely be linked to maybe some level of adrenal insufficiency.
They potentially could.
Potentially.
Yeah, and so it's a pretty simple test to do to check a cortisol level, and that can give you a lot of reassurance if that's nice and robust. And that's a pretty simple, again, it's a pretty simple one to do.
Yeah, and you know what, as a nurse, I have to say, if you are going in for regular blood work, it might be something to ask the doctor to add in and go in at, and like you said, to have it drawn at 8 a.m. fasting. Because I know a lot of, especially, a lot of our lab work doesn't need to be fasting, but this, you say, needs to be fasting and right around that 8 a.m. time. So potentially, Emily, that might be a next question for your nephrologist whenever you have your next set of labs to come do. All right, so this is from an anonymous attendee. Their 4-year-old is on prednisone daily for about a year, ranging from 2 milligrams per kilo to 0.5 to help with manage his nephrotic syndrome. They switched meds recently and have been able to lower his dose every other day. Assuming we're able to taper him off, will his adrenal glands recover? And if so, do you know how long this would take? And I know that you kind of covered that, but would you review that maybe again?
Yeah, I fully expect that those adrenal glands will recover. In terms of how long it'll take, it generally takes about as long as you've been on it, if it's less than a year. But if it's been more than a year, it's usually 6 to 12 months after you've stopped the steroid for your adrenal glands to fully recover. Some people recover a lot faster, some people take a little bit longer, but most people will recover within that time frame. That's
great, thank you. This question is from Kent. He's been on 5 milligrams post-kidney transplant for 34 years. Now, this is a common thing. A lot of our transplant patients are on. I know, right? He's a longtime patient and advocate, I have to say. So a lot of our transplant patients within our disease space are on prednisone for, I want to say sometimes forever, maybe like Kent. Is there a reason, do you think, to reduce his dose at this point? And it has never been indicated, but he's kind of curious about your opinion. And along with that, for our transplant patients, that low dose, is that enough, especially for chronic, almost a forever time? Would this be a concern that maybe people like this need to see an endocrinologist to have maybe that stress dose on them or in their kind of toolkit in case an episode of stress or injury were to happen?
That's a great question. So on prednisone for 5 milligrams a day, remember that there are wonderful things about steroids. I always have to stress that when I talk about all of the consequences that can happen with steroids. But steroids do a remarkable job in helping to keep immune systems calm so as to not fight against those transplants. And so if you need to take the steroid for that transplant, by all means, take the steroid for that transplant. That is the most important thing. Now, with regards to managing if there is iatrogenic adrenal insufficiency, so first is determining if there is. When an adult is on prednisone of 5 milligrams a day, the likelihood, again, of adrenal insufficiency is not significantly high. Most consider that 5 milligrams of prednisone a day or less is fine, and you don't need to worry about iatrogenic adrenal insufficiency or stress dose, unless, of course, you're having those symptoms. But if you're not having those symptoms and you're doing really well on that, this is generally not something that you need to worry about or to need additional stress dosing. If you're on higher chronic doses, it certainly is something that you need to consider.
So following up with another transplant patient question, Jen has a question. And Jen, I want to say I will be sending out the recording. So it's no problem that you kind of came in a little bit late. She's curious. She's on 10 milligrams a day. She is post-transplant. She doesn't see insight that she would be getting off of that at any time, but she's wondering if there's anything she can do to minimize the symptoms related to this insufficiency.
So are you asking about the symptoms of being on prednisone 10 milligrams a day or symptoms of insufficiency? Because the symptoms of being on prednisone every day, and that is a chronic issue that you are not alone in trying to manage those symptoms. And honestly, I would recommend that you talk with your physician about how to best manage and adjust those. As we mentioned a little bit earlier, some find that splitting the dose or taking the prednisone at a different time can manage some symptoms they might have. On the other hand, if we're talking about adrenal insufficiency, say you're on 10 milligrams a day, but every time you get a fever, you end up in the hospital with hypertension, low blood pressure, then in that case, you would definitely want to look into assessing whether or not you have adrenal insufficiency. And one of the best ways of checking that is a morning cortisol 24 hours after you have stopped, or 24 hours after your last prednisone dose.
That's a great answer. Shannon has a question. Her daughter is steroid. She was steroid resistant with FSGS and now is 2 years post-transplant. She's on a daily 5 milligrams for life. And she's curious, again, about this testing for adrenal insufficiency. And so I guess maybe, to clarify, when would you suggest someone to get this test done?
Yeah, so for adults, if you are on more than 5 milligrams of prednisone a day and you have any symptoms of adrenal insufficiency, I would recommend that you get the testing done to assess what your adrenal function is. For kids, if you're on more than 10 milligrams per meter squared per day, and I have the dose meter squared per day up there, that formulation, to figure that out. If you're on more than that, then we generally would like to check that kiddo out to make sure that their ability to manage fevers, illnesses is appropriate with regards to how much cortisol they can secrete.
Barb has a question. She has been on various doses of prednisone for minimal change disease for 15 years. She's at 5 milligrams and she does have fatigue, joint pain. She has some weight gain. And when she mentions adrenal insufficiency with her physicians, they have no interest in testing her. So her question is, when you have to be on prednisone for the foreseeable future, again, is it beneficial for testing? I guess too, I think part of this question too that's significant to me as a nurse is that the physician is not really interested. So at this point in time, would you recommend that she look into getting a referral to an endocrinologist so that they might assess and see if the testing is appropriate for her?
I think so. Yeah. I think it's important that if you have a concern, it be addressed.
Yeah, especially if she's been on prednisone for about 15 years and she has been asking for it. So Barb, I would encourage you to maybe reach out, ask your insurance or find out from your insurance company if you need a referral, or if you can just call and get, find an endocrinologist within your plan that you don't need a referral for. So I would contact your insurance company first and find out what you need. This is a great question. My child has been taking a low dose for many years as part of an anti-rejection protocol. Yes. And I've noticed that when she gets sick, she crashes hard and fast, and normal childhood illnesses often land her in the hospital. Would this be something that a stress dose would help with?
Yes, you definitely need to get to a pediatric endocrinologist ASAP.
Can go in a little bit further with this question, because this is probably not the only person that's going to watch or listen to this and have the same question, is what does it mean to crash hard and fast? Are we talking about repetitive vomiting for no reason? Are we talking about a fever? Are we talking about cold sweat? What does this look like?
Yeah, that's a great question. So this is a typical scenario that we will get when I was discussing that sometimes we don't find out about these kiddos until their third or fourth time in the hospital for a routine illness. And so, for example, if you get a gastroenteritis and the whole family gets vomiting and diarrhea for 24 hours, but kids with adrenal insufficiency, they get profoundly dehydrated. They get more vomiting than seems appropriate for the rest of the family, more diarrhea than seems appropriate, more lethargic. So lethargic is a catchphrase. It's not just fatigue, it is a fatigue that hits you so hard you can't get up, even if it means going to your favorite store for ice cream. So lethargy, low blood pressure, low blood sugar, and symptoms of being sicker than the illness should suggest that you be. But this is a story that you're not alone in this. And this is a story that certainly makes us concerned that there is iatrogenic adrenal insufficiency occurring, and that these are repeated adrenal crises that are happening. And these can be prevented. So, for example, when our kiddos who have iatrogenic adrenal insufficiency then do have a vomiting illness, they take their stress dose steroids at the start of that illness, they can prevent getting super sick, and they can certainly prevent getting into trouble and needing hospitalization.
That's great. Thank you for that. Rita has a question, and I see another question kind of down below that I'm going to follow it up with. So Rita was on 60 milligrams of prednisone for minimal change disease, and she was able to taper off early in June. About 2 weeks later, she started having body pain, joints, bone, muscle weakness, hair loss, and she's close to 4 months out from stopping the prednisone. How long might this go on? The nephrologist has requested a DEXA scan. She's 61, so it's probably a good thing anyway, she says. But is there anything I can do to help the pain? And if you look a little bit further down, Dr. Chambers, another question says, how do patients know the difference between adrenal insufficiency, normal taper effects, and adrenal crisis? So I'm wondering if some of this isn't that normal process where like you talked about in your talk, where the adrenal glands takes time to recover, I guess.
They do. And so, yes, so adrenal insufficiency is when the adrenal glands can't make enough cortisol. And the main risk with that is provoking an adrenal crisis. An adrenal crisis is where you can't make enough cortisol to keep yourself alive or out of shock in the time of a significant stressor. So day-to-day feelings of weakness, fatigue, those can be signs of adrenal insufficiency, but they could also be signs of glucocorticoid withdrawal. The only way you can really be absolute certain is that one or the other is if you are on enough steroids that it's covering maintenance cortisol production, then it's glucocorticoid withdrawal. But if you're on less than that, it could be a degree of the adrenal glands recovering themselves. If symptoms are mild, you let those adrenal glands recover themselves. And that's where I was talking a little bit about tolerance. If those symptoms are significant, or if you're fainting, if you are dizzy, if you are weak, if you feel really a lot of pain, then that's a good time to discuss whether or not a low dose of hydrocortisone, which doesn't have as many effects on bones and blood sugars, blood pressure, mood, if that may be helpful as a transition point in the weaning. When you've been off for close to 4 months, great job. You are likely in a good recovery point and you should start to see things improve. But if they are not improving, I think a DEXA is a fantastic idea, especially given your age, to look into if there's any bone issues that might be causing this pain, and to look into other issues. But you can ask your nephrologist if they think that this might be a prolonged response to the prednisone coming out, and if there might be another way to kind of bridge that recovery. And hydrocortisone at low doses is often a nice bridge to be able to help with a lot of those symptoms.
When you talk about hydrocortisone as a bridge to maybe help with some of those symptoms, how is that taken? Is it a pill?
It is a pill. Yep.
Okay.
It's a pill, and prednisone has a long half-life. So when we think about potencies and half-lives, that's how long the medication is in your system. Prednisone is in your system for a good 24 hours or so. Hydrocortisone is only in your system for up to 12 hours. Most of that is within the first 6 hours. So the reason that we like hydrocortisone is when you give hydrocortisone in the morning, it kind of mimics a little bit of that boost, but then it wears off in the rest of the day when your cortisol should be low and thus is not causing more suppression over time. And we use small doses. So again, 1 milligram of pred is equal to 4 milligrams of hydrocortisone. So if you do 5 milligrams of hydrocortisone, when you were used to doing 5 milligrams of pred, you are actually on a significantly smaller dose.
Yeah, absolutely. One last question, if you don't mind. We are at the top of the hour, so this will be the last one for today. I appreciate you being here so much, Dr. Chambers. This has been a really great conversation with our community. Tiffany has a question, or really it's kind of a statement, and maybe you can answer or give a response. She's been concerned about adrenal insufficiency for years, even before her kidney diagnosis. She believes her cortisol spikes in the evening versus the morning. It's been diagnosed as major depression disorder. Now that she's on steroids, she's afraid that it's actually worse. She was on as high as 120 milligrams of prednisone, and now she's at 10 milligrams every other day. She says, my morning fatigue has caused me to pull over and take a nap to avoid a crash. What would your response be to Tiffany?
Yeah, I think it would be a really good idea to get in with an endocrinologist. That's a lot of steroids that you are on, and 10 milligrams every other day. Again, there's some variation into how we absorb these steroids. And while prednisone can be in your system for 24 hours, it does wear off over time. And you may be having some significant fluctuations in your body's cortisol that it's seeing, either from the prednisone or from your own cortisol production. And that can definitely lead to some symptoms. So I think it is very worthwhile to look into meeting with an endocrinologist to hopefully figure out if there's a way to stabilize that a little bit.
This has been a great conversation. I think you know, everyone that's been here today and everyone that's going to be listening to this in the future, I think it's really important for us to really remember about the significance of what you do as an endocrinologist, especially in our disease space where steroids and the long-term use and the chronic use and the high dose use of steroids is obviously the first line treatment right now for most all of our diseases. So as just a parting words, I would probably encourage people who are concerned about iatrogenic adrenal insufficiency to talk to their doctor. You might also want to consult with your insurance company to find out if you need a referral to an endocrinologist in your area. If not, if you don't need a referral, then that means that you can probably call and try to get your own appointment. This is another specialty, so I'm assuming that, like most specialists, it does take sometimes it takes a bit to get into. Dr. Chambers, thank you so much for being here. It's wonderful to see this interdisciplinary work that you do, because we know that you do see patients that have had transplants and have been within our disease space. So we really appreciate you being here and lending your voice and your knowledge and your expertise to us today. Thank you so much. Thanks everyone for being here. And I look forward to seeing you at our next NephCure U.
Great, thank you so much.
Thank you.
Bye.